cancer, it is the papillary carcinoma, much more common in the background radiation history. Hurtle cell has got a poor prognosis. Papillary has better prognosis than follicular. And medullary carcinoma is associated with the MEN2B is what you have to basically remember. So the patient has dysphagia, you are finding a ring-like structure which is an example of a Skarsky's ring. So dysphagia in case of the Skarsky is usually for the solid food which can't pass. And there will be a concentric symmetrical narrowing is the classical feature, and it contains esophageal mucosa above and gastric mucosa below. That of this narrowing is what you see, and it doesn't contain any esophageal muscle. Now in the gastric cancer you have two varieties, a diffuse type and a intestinal type. So what is the difference between the diffuse type and the intestinal type? Let us look into it. Basically, intestinal type of gastric cancer is very common with H. pylori infection. So nowadays we are using a lot of triple therapy to eradicate H. pylori. Worldwide there is an awareness about H. pylori. So the incidence is decreasing. And but overall if you take diffuse type and intestinal type, intestinal is still more common, though its incidence overall is decreasing because of better treatment of H. pylori. Still its incidence compared to that of diffuse type, it is much more common. It is more common in the male than in the females, where the male to female ratio is 2:1 in intestinal type, 1:1 in diffuse type. So I leave the literature for you. A young mother brings her 2-year-old son who is having recurrent belly aches, and the baby has been squatting with his knees in his chest, which is causing relief. Classical story of intussusception. So you can see on the radiograph how a intussusceptum looks like, and the typical ultrasound appearance of one going into the other. So it is the Meckel's diverticulum, most commonly is the leading point of the intussusception, is the leading point which you should remember for the NEET PG exam. Ileocolic is most common type, and diagnosis is confirmed on abdominal ultrasound, and it can be corrected by giving a air and barium enema, is the way by which you can pull out the intussusceptum, is what you have to remember. This is a favorite question, bhai sahab. If you answered this wrong, you need to seriously drill down and then prepare for exam. Typically, catgut, chromic catgut, polyglycolic, polygalactin, polydioxone and collagen, they are all considered to be absorbable. Silk, linen, cotton, horse, nylon, polyester, polypropylene, they are all non-absorbable sutures. Coming to surgical site infection, it can very much happen because of the environmental flora that is there in the IOT, in the OT, and the superficial infection, it requires a resurgical exploration of the wound. Coming to perioperative or a preoperative antibiotic prophylaxis, what is the recommendation? Half an hour before surgery is considered to be the classical recommendation. Grade 3 is a contaminated wound where there is a gross fecal material spillage into the wound, is what is called grade 3. So clean wound, clean contaminated, contaminated and infected wound. You must know the various classes. In the testicular cancer, seminomas, they typically metastasize. Lymphatic spread is more common rather than hematogenous route is what you have to basically remember. Seminoma is more common than non-seminoma. Cryptorchidism with undescended testis can lead to the development of the seminoma is what you have to remember. With regard to the obstructive jaundice, So Courvoisier's law typically states, look how is the gallbladder, is it distended or is it shrunken, based on which you can know whether it is cholecystitis or whether it is a pancreatic cancer, is what you have to basically remember in a case of obstructive jaundice. Coming to sepsis, so we don't use any erythropoietin to treat the anemia. After all, it is not the bone marrow depression responsible. SOFA, Q-SOFA, what are the criteria? Respiratory rate, systolic blood pressure, altered GCS, they are the part of the score determination called the Q-SOFA score in case of the sepsis management is what need to be remembered. In peptic ulcer, early dumping, late dumping, you must know all the differences. Typically, early dumping will have predominantly gastrointestinal symptoms like abdominal pain, diarrhea, borborygmy, bloating, etc. and vasomotor symptoms like flushing, palpitations, etc. Whereas late dumping is all hypoglycemic symptoms with sympathetic activation leading to perspiration, palpitation, hunger, etc. So early dumping, late dumping differences, post-vagotomy, favorite topic from times immemorial which you have to be doubly sure. How many types of dressings that you know in surgery? So we have a occlusive dressing, so non-adherent fabrics, absorptive dressing, occlusive dressing, creams, ointments, solutions. There are the various forms of dressing. I leave the literature for you. In absorptive dressing, you use the wide mesh gauge. Not in case of the occlusive dressing is what you have to basically appreciate in this question. I'll leave the literature for you to understand this, a long discussion. Now,